Well, السلام عليكم. Greetings, مساء الخير وصباح الخير, depending on where you are, um, uh, corner of the world, inshallah. So my name is Sundus Saad. I am an adjunct assistant professor currently at the Ohio State University in the United States, and I am very privileged and happy and delighted to be part of the ABCDE team. Thanks to Dr. Huda Amir, as always. She's very successful, mashallah, in pulling people from their busy schedules to give back to the rest of the team. So proud of everyone who's joining now. ربنا يكرمكم جميعاً. Thank you so much for joining. And I will be talking about menopause in general, mainly really the updates and the highlights of how our perspective of this milestone of a woman's health have changed. I know that some of you are bilingual and some of you have preference to Arabic language. And I don't know if you guys know this. Today is the day of the Arabic language. So if you have any preference to which language I conduct this lecture, please raise a hand or leave a comment. I'll be more than happy to adjust the content and give parallel to the terms so you can better use it with your Arabic speaking patients, okay? So I hope that everybody can see my slides. And I'm sorry, I don't necessarily know you guys in person. So I would really love it if you advocate for yourself to ask any questions or if the slides are not necessarily clear. Thank you, Mariam. Okay, so overview of the menopause terminology. Words really matter. So from my perspective as a bilingual provider, I do notice that a lot of times we fail to deliver terminology that is not only medical jargon. Even if you want to tell your patient their diagnosis, you don't have to give them literal translation. And a lot of times I've noticed that we ourselves do not necessarily use the medical terminology in an accurate manner. Sometimes we've inherited those and sometimes they're, like they're not up to date taxonomy, meaning the agreed upon in the medical society. So I'll try my best to update those as we go. Why do we have menopause? Why don't we just have, puberty and menopause and periods forever? What is the biological or physiological cost for that? What is the impact? Why menopause now matters and why is it brought to our clinical attention? What clinical issues can actually encounter you, whether it's physiological or pathological, and how you can manage that? It is a health milestone, right? So whenever you want to discuss menopause with women or even family conferencing, you want to remember that it is like puberty. Menopause is another milestone of a person's life. It's not the end of her life. It is a milestone in her life, right? And doesn't necessarily equal somatic aging, meaning reproductive aging is not the same as somatic aging. يعني شيخوخة المبايض ليست شيخوخة الجسد أو الهرم. That's why we can treat it, right? So for people who identify, for instance, with religious traditions, they keep telling me, for instance, Muslim patients, they keep raising hands and say, but there's no treatment for aging. Ovarian aging is different than somatic aging, and the way that it expresses itself sometimes can be treated and managed and improve quality of life, if not even preventing pathology and disease. It can be natural, so it can happen naturally in most women, and it doesn't necessarily give you any symptoms. It can happen without necessarily us intervening, and it can happen prematurely. Premature ovarian insufficiency or premature ovarian aging can happen due to many causes, and we will just highlight some of those in a minute. It can be completely asymptomatic, by the way, and it can be symptomatic. The thing with the asymptomatic menopause is it's very hard to tell that women are truly asymptomatic or they just don't reach out to physicians, clinicians, or healthcare provision. Hence, we really don't know if it's like a 100% incidence that women would experience symptoms during menopause. That disconnects between our research subjects, our patients, our caretakers, and the research findings is related to that short bridge between us and our patient population. It is an opportunity to assess health status beyond reproduction. So it is a good chance when a woman comes in to a woman to say, I haven't had a period for over a year. Man, this is your opportunity to talk about preventive screening. Well, let's focus on something else other than contraception or having babies or like being worried about what medications to take. Let's talk about the whole body now beyond your reproductive role as a female. Menopause is cessation of periods. Nonetheless, there is a term that we underuse and don't necessarily understand what it means. It's the climacteric. It is the whole transition from the moment a woman notices that there are some changes to the moment that she graduates that ovarian aging symptoms or a period. We call that climacteric, right? Women in general have positive attitudes towards menopause unless they have severe symptoms, and that can be a risk factor towards negative attitude. Oh my gosh, like this is the worst thing. I wish like we don't have to go through this. Why men don't go through this, blah, 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 all of these kind of negative attitudes that do not necessarily connect them to timely management in a physician's office or provider's office. Life expectancy nowadays is approaching 80 years of age, at least in the Western sphere. And that means women can live almost half of their life postmenopausal. So it's really worth understanding how the ovarian aging impacts somatic aging and ability of the body to heal and live well with a quality of life. Another thing we need to recognize that there are 6,000 women every day entering menopause. So this is a daily encounter incident that you should cross paths with, regardless of what your job description is, whether you are an endocrinologist, oncologist, primary care, OBGYN, surgeon, regardless where you fall on the spectrum of care provision for the whole person, you will encounter menopausal symptoms at one point. No universal syndrome, right? There are symptoms under the menopause or ovarian aging that can be contributed to that ovarian change or switch. Terminology. What is menopause, right? Menopause is simply that cross-sectional point where periods actually stop. That's what menopause is, the pause of menstruation. Final menopausal period is a retrospective diagnosis that we look at 12 months later. Any bleeding in between disqualifies the FMP date. So when I say final menopause period, I'm talking about 12 months, no bleeding whatsoever. Okay, and that is a retrospective diagnosis. And it's very important in determining that where Milestone started and how you are going to treat that woman, understanding and bearing in mind how many years has she been exposed to estrogen progesterone fluctuation. Pre-menopausal, any woman who did not yet hit the final menopausal period. Okay. Post-menopausal, any woman who has had 1 full year of 12 months of post-final menopausal period. That when we call her post-menopausal, she has to have a year under her belt where there's no bleeding. Menopause transition, it's actually a period of time, and I will show you better on the next slide. That would be more of a visual. Perimenopause, it's actually looking at the stages of reproductive aging. Premature menopause, anytime a woman gets to the final menopause period before 40 years of age. Early or late menopause, whenever the woman gets to that 40 to 45 years, we can consider that more of an early menopause. The late menopause, which happens a lot in African women, and I want to emphasize that we don't have enough studies or research on different ethnicities. So what we identify early or late menopause is actually subjective, and I do not recommend using that as a scientific term. I would rather use premature menopause because it's an objective definition. Premature ovarian insufficiency is a new term replacing premature ovarian failure. Ovaries are just insufficient to provide enough estrogen and progesterone to take the woman up to the 40 years mark, where she is at least getting enough protection for her cardiac health as well as bone health. Induced menopause is something that environment or medical society can induce, like oophorectomies, hysterectomies with bilateral oophorectomy, meaning there's no estrogen, progesterone, chemotherapy that negatively affects any germinating cells, medications, toxins, excessive stress like wars nowadays actually contribute to premature ovarian insufficiency. And that is usually a problem for women seeking fertility. So you would probably encounter that more on the OBGYN side than merely on the primary care spectrum. The climacteric, and I'll go to the next slide just to kind of give you, this is one of my favorite outcome of the NAPS, which is the North American Menopause Society, which is a collaboration between Canada and the United States. Lots of providers have come together, really interested in improving quality of women after they hit that milestone. And we found that STRAW stands for Stages of Reproductive Aging Workshop. Okay, and this is a very important. Is there a question? Okay. So the Stages of Reproductive Aging Workshop is really a great way of looking at the menopause as more of 7, more of like plus 10, but it's actually like 7 stages. As you can see here early, can you see my slides? Maybe I'm not moving the, yeah, I want to move. Can you see the mark? Can you see the cursor now?
Yes, please.
Perfect. So once we have the first milestone, which is menarche, that kind of announces puberty for female patients, the female side of the population. And in that, there is an early side of the reproductive. There's a peak of reproductive stage. So as you can see, we have 3 stages in the terminology that we can use. That is reproductive in the first 4 stages of the straw. And then there is the menopausal transition in the middle 2. There's the post-menopause in the last 4. So we have 10 of those that are like broken into main 7 ones that we deal with. That's how they present to us in the clinic, right? In the menopausal transition, it's usually the -2, -1 stages, during which, as you can see, criteria, menstrual cycle is the biggest determinant and predictor, or where a woman falls on that spectrum of the straw, right? So once your period starts being regular, you are at a peak of reproductive age group. And then clinically, you can't really figure out -3B unless you do some blood work. And personally, I use the AMH, which is anti-Mullerian hormone. I will come to that when we talk about the clinical evaluation. But this is gold, really, this is gold. It has limitations, and I'll come to those, but this helps a lot in answering women's physiological questions. Like, can I have a baby, doc? Like, can I now have a baby? When she starts noticing subtle changes in flow or length. So I can counsel her that your chances may or may not be good. I can help you by looking on some of these clinical labs and then refer to IVF or MFM, depending on her clinical comorbidities. But the perimenopause is actually the menopausal transition, right? And plus the first stage of postmenopausal. And that's when you see women in the clinic. Oh my gosh, the hot flashes are killing me. And that's really a good time to contemplate treatment. Okay, in these stages, that's where we found that there is a benefit rather than risk if we provide women with counseling, education, and treatment. I just want to tell you, especially if we have like females in the audience, I'm sure that you guys will start projecting this on your own acquaintances, but once you start noticing subtle changes that are less than 7 days of the period, changing in the flow, it was heavy and it's less, it was dark color and it's now bright. I don't feel like my period is going to come, so there's no much of a PMS anymore. Or like I have significant symptoms when the period is about to come. I'm sleepless, my sleep all over the place. I have weird systematic or constitutional symptoms. I never felt that, doc, before. Okay, so when a patient brings that up to your attention and says, this is a change, you need to attend, okay? And you need to remind your patient, what are your goals for this stage of your life? Do you want to have a baby? Do you want contraception? Do you want to control your bleeding? Do you want, of course, the most important question, do you want to understand why this is happening? Let's rule out potential pathologies, but most likely this is what's happening. You're going through menopausal transition, okay? Great labs that we can actually use. And I know that some of you thinks that menopause doesn't have any clinical labs. Now I think because ovarian aging is happening much more often than we would wish, and it's happening sooner. And because women are really pursuing career and their fertility options are like delayed until after 30, we really need to find biochemical markers. We can't just assume that there is no clinical or biomarkers that can be utilized to improve. And I think now the research is going towards how can we improve AMH levels, natural methodologies, and maybe medications, just to help women conceive. And of course, this is not ideal, but the pace of the current culture is very, it kind of trades expediency versus wellness, right? So I think this is our right to understand what's happening now in the scientific society and bring our own insight into it in improving women's life, and start counseling early on so they would make further decisions and decide what priorities they want to have in their health journey, right? So the straw stages, I'll be more than happy to share the references, inshallah, in a minute. The significance is that gives you a consistent classification of menopause. Most of the time, by the way, patients do not come to us because they want medications. They just want to understand what's happening. And a lot of times it's, do I have thyroid issues? Do I have diabetes? Is there any way that I could be pregnant and I'm losing babies? At least these are the most common questions that I notice in my observations or clinical interactions. This research has facilitated us to distinguish health effects of ovarian versus somatic aging. I cannot overemphasize this insight. It's like a light bulb, honestly, like when you deal with patients. Clinical tool to guide assessment of fertility and contraceptive needs. I feel like I'm repeating myself here, sorry. And then understand that the taxonomy, يعني تصنيف, يعني الأسماء, المسميات, المصطلحات, the names, nomenclature, terminology that we are exchanging as physicians, we are on the same page. A lot of times, I notice that we use the word premenopause as one that we exchange with perimenopause. We really need to start focusing on how we exchange women's health terminology. We tend to be loose when it comes to that. This way, I think, kind of improve our standardization of how we can stage women on that system and how can we recommend treatment and manage symptoms, right? And then I think this can advance the research in menopausal period of time for women's health. The limitations, though, very interestingly, is that it only applies to healthy women. So we really need to expand the research beyond women who have no medical comorbid conditions or have had like issues, PCOS, or their ovaries anyway, they were erotic, right? If the ovaries initially were like polycystic or like had insufficiency or multiple cyst or chocolate cyst or endometriosis, that hormonal derangement of what we believe is standardized norm for women's health may not necessarily make this staging workshop applicable to that patient, unfortunately. It also recommends against applying it to 7 subgroups of women, which honestly, I would have to say that in the US, smoking is not as common as before, but I know that in the Arab world, now women are picking up on smoking as much as men, unfortunately. Women with BMI more than 30, so if you cross the obesity, women who have undergone hysterectomy, so the feeding tissue, the endometrial tissue that we still, like, by the way, do not know what kind of contribution the endometrial tissue have. So let me give you this idea because I'm very passionate about women's health, right? We deal with women's health as they are the ovary of they are the role of the ovaries. And they are the stars of the show, right? We don't really know how the endometrial lining, how the uterus is playing a role in the HPA axis. Because there's an ethical dilemma. The uterine cavity and endometrial tissue is sacred. It's very well protected. We don't touch that unless there is a baby or we are trying to slough off, a hypertrophic or proliferative lining. But we really don't know how the uterus works. So we found that the women who have had hysterectomy may not necessarily benefit from that staging as much. Women who are engaged in aerobic exercise that is heavy, so female athletic syndrome or the triad, once your HPA axis is overwhelmed with the with the decreased fat tissue and there's not enough aromatization of the DHEA, you can't fully apply that staging of workshop. Also, women with chronic menstrual cycle irregularities, uterine abnormalities, or ovarian abnormalities. There's also like diverse populations. Again, إحنا women who are Arabs, African, non-white women are not really part of the research, are not well represented. So that's where your role comes in, inshallah. Ovarian aging, as you can see that the fertility is one of the biggest diminishing effects of ovarian aging, right? But there are multiple factors. Genetic, so when do your aunts and mom and whether paternal aunts or paternal or maternal aunts or your mom or your sisters, when do they actually experience menopause? That can give you a little bit of a crude estimate of what the genes of that woman looks like. Environmental factors, hormonal regulations, if you take hormones throughout your life, if you take OCPs or have an IUD. So we really don't have a way of recognizing how our contraceptive hormonal modalities impact ovarian aging. We don't do that kind of study because they serve a clinical indication, right? And then potential indicator that can be used biochemically or biomarkery is the AMH. AMH is anti-Mullerian hormone. AFC is antral follicle count. How many follicles are in the ovarian side? And then like aging ovaries actually do not have many follicles left, okay? And the ovarian aging process starts pretty much by ovaries decreasing in size. They become atrophic. That's what happens in general. We don't need to use a germinating tissue. That's one way of the body in aging of saving blood supply, subhanAllah, like how you can save the blood supply from an organ that is not necessarily working. And then when the supply is gone, then atrophy is the natural result of that. Number of follicles will decrease substantially. Production of inhibin and AMH produced by ovaries will decrease. We don't know actually if they are produced by other tissues. That would be interesting to know. Remaining follicles respond poorly to elevated FSH and LH, meaning the follicles also, they are like demented. The follicles اللي بتكون موجودة بالovary, even if you see them on the ultrasound, they may not necessarily be as responsive. That's why primary ovarian insufficiency replaced failure. It's like how the pancreas works, right? Pancreatic insufficiency leads to insulin resistance. So that's why they are also very strongly connected. The ovulation can go over the place, and that's why women can actually have, withdrawal periods in between the area. So it's like an ovulatory or dysfunctional uterine bleeding, depending on which term you guys use. Sorry, that was fast. Symptoms versus impact. Remember, not all symptoms actually will negatively impact quality of life or will bring that patient to you in the clinic, right? Symptoms can be many. Estrogen has like a receptor almost in every vivid tissue in the body, right? Like for instance, teeth, like postmenopausal, a woman loses bone tissue density almost a fourth of what it was premenopausal. That's why women are likely to use their teeth if they don't regularly take calcium and vitamin D. And that's a key counseling when a woman comes postmenopausal and they're like, salam, now it's about time to talk about your vitamin D and calcium. Are you walking in the sun? Are you getting enough calcium? Are you taking vitamin D? Did you know that postmenopausal, your teeth density can actually reduce? Something to teach your patients. I always remind people that doctor is a Greek word for teacher. If we don't have passion for teaching, I don't think we can deliver the optimal healthcare. So as you can see here, the hot flashes, night sweats, irregular periods, loss of libido, vaginal dryness are the common ones that we see, and we can relate those to menopause. But what some doctors may not know, that mood swings, fatigability, skin and hair changes can actually be contributed to menopausal change. So if a woman comes in and says like, oh, gosh, since my period started being irregular, all of these symptoms are happening. What can I do with this? you have to believe them. Give them the credit. They're not faking it. Don't ridicule it. Don't dismiss it. Listen and take notes and figure out how you can help this woman and how much that is impacting their quality of life. Another important piece that I would recommend, do not determine, okay, there is a hand. Kareem, you have a question?
Yes, sorry for interruption, but can you hear me?
Yes, please.
Okay, about the part that says loss of libido, I actually have read, I don't know if this is totally correct, but I have read that libido does not decrease with aging in both men and women. And in cases of women, it may be due to the like a side effect of the genitourinary syndrome. That's like the dyspareunia and so on. So
That's
that was my
actually
comment.
Yeah, that's actually a good point, Kareem. The idea from the loss of libido, it's not necessarily always physiological. So you are correct. There's a potential that GSM, which is genitourinary syndrome of menopause, can be the contributing one for loss of libido. And that does not necessarily present itself as a clinical, as a direct effect of aging, but it can be actually of ovarian aging. Remember that ovaries actually produce some part of the testosterone next to the adrenal glands, right? So adrenal glands are the one that produce the chunk of testosterone for both men and women, right? That's the, that's part of the adrenal cortex where you produce the 3 corticoids, remember that? So the testosterone is one that is produced by another organ. Nonetheless, with ovarian aging, there is a potential to decrease testosterone, and actually loss of libido can be an effect of that decrease in testosterone. What you have read is related to somatic aging, not ovarian aging. And there's actually in men something called andropause. That's why now there's an increase in testosterone injections. Now, a lot of homeopathic people in alternative medicine and complementary medicine are claiming that the life pace that we live nowadays does cause adrenal fatigue, leading to these symptoms becoming part of an organ insufficiency rather than natural aging. Yeah, and there's nothing natural about our life nowadays, especially during the pandemic, right? So I do believe that research is growing out that period of time. And also remember that loss of libido does not always reach the clinic. So while research can deliver that piece of information to you, it's not necessarily consistent across the research. I'll be more than happy to provide references to that. I'll leave a note to myself here, actually, but that's a good point.
Okay, thank you, dear doctor.
You're welcome. Perfect. So while these all are, that could be quality of life measures, and there are actually questionnaires, I'm more than happy to share links of those as well, quality of life for menopause, that you can provide those. I personally do those in my clinic because I specialized in menopause when it comes to primary care. So I provide the full spectrum of family and community medicine. Nonetheless, I have women's health clinic through which I focus mostly on delivering wellness, not just treating illness, right? So there are quality of life questionnaires that you can use to see how much of these symptoms are actually impacting the day-to-day life. People don't want to socialize. People don't want to talk to anyone. It's impacting relationships. I see another hand. Any questions? Kareem, you still have your hands raised. Do you have a question, or you just...
No, I didn't know that it keeps being raised. I thought it was a one-time thing. I'm sorry.
Okay, no problem. You can actually go and look. Yeah, good, perfect. You got it. And then aching joints, burning mouth syndrome, all of gum problems, digestive problems, all of these things. And of course here, osteoporosis is not a symptom, of course. Osteoporosis is a diagnosis, okay? And this is huge. I'm so proud of this, okay? Osteoporosis is a woman's disease. It's almost exclusive to women. Okay, and this is a start, because one of my strong passions that women struggle with musculoskeletal system, and its pathology is different than men. There are receptors of hormonal hormonal profile that men do not have negatively impacts women. Yet the scientific society always endorses like, oh, you can exercise like a man, you can do things like a man. This really necessitates almost falling into the female athlete triad. But the fact that now we have a win in the research arena, in the scientific society, that osteoporosis is exclusive to women. If a man has it, then there should be an underlying pathology related to calcium, vitamin D, regulations like parathyroid issues, or even cancers. But osteoporosis is almost exclusive to women's health. And it is currently that we live 40 years in menopause now, it's almost inevitable for women to go through it without counseling. So you can save women from osteoporosis if you learn your best bet, up-to-dates and current guidelines about menopause. So why menopause have become out of nowhere very important to the clinical world and research? Because it's costing the system money. Women are living longer, and post-menopause, their cholesterol, triglycerides are increasing, and the estrogen effect, protective effect of cardiovascular disease is gone. And they're living longer. We're not killing them enough now because they're not having as many babies. Maternal morbidity and mortality used to take women much earlier in age. Now they're not having as many babies and they're living longer. So the system is noticing like, oh my gosh, there are more women with cardiovascular disease, and their symptoms and presentations are different due to their hormonal profile being unique. So increased cholesterol, osteoporosis, and of course mood swings, these are very common to bring women to your clinic and you not even crossing your mind that, oh, you're postmenopausal or you are perimenopausal. Let's shift gears in our discussion and look at your hormonal profile. How can we help you cross that milestone properly? And then there will be symptoms like the DSM, genitourinary syndrome of menopause. This is the replacement of GUS, which is genitourinary syndrome. It is genitourinary syndrome of the menopause. Okay, this is specific to hormonal fluctuations and happening, and it's still under studying, right? It's not really an ideal term, nor it is well and fully understood. Okay, alhamdulillah, we're expanding research in that side. There's the irregular bleeding that they would make them come in like, oh my gosh, I'm spotting and I'm should I pray? Should I fast? Should I have sex? What do I do with this, right? Infertility, it's huge, honestly. Like this is huge. In the Western society, women come in to me and they're 38 and 39 and AMH is less than 0.4. It's sad, right? That's a premature ovarian insufficiency and it's rarely even checked. So infertility is huge, at least in the modern societies, if you want to, like contemporary times. Vasomotor symptoms, they don't always bring women in, but they are very more common than what we have quantified in research, simply because women just don't hit the clinic step in that. Vasomotor symptoms can be hot flashes, feeling sweaty, feeling cold. So the temperature regulation is not yet fully understood, but it happens in that perimenopause transition. And some women actually, if you go back retrospectively, they would report it even during their premenstrual syndrome or premenstrual symptoms. Slower GI, it happens often, more than you can think it is. Gosh, doc, I started feeling heartburn. I've never had heartburn even during my pregnancies. And now I'm hitting my 49 and I'm just having heartburn. I start asking them about their menopausal symptoms. How are your periods? Do you have hot flashes? So it can be actually the key for you, for women around that perimenopausal transition, to ask about their hormonal profile. It is always a good chance to explore that. Weights, women always claim that weight gain happens in menopause, but it's really very hard to say that menopause causes weight gain. Nonetheless, menopause profiles were found to change fat distribution. So women may notice that fat accumulates more in the truncal area, and weight gain due to menopause cannot be a culprit for more than 5 kilograms, right? So 5 pounds to 12 pounds, yani 3 to 5 kilograms max. You cannot blame the menopause for more than that, okay? Lifestyle prescription always works for weight, okay? And then of course there are hormonal profiles. There are some women who are challenged in hormonal profile, and for those I would always dig deeper in what type of food they're eating, not how many calories there is in their daily diet. Sleep disorders is very common. Gosh, you have no idea how women like experience insomnia, have like a lot of issues with difficulty initiating sleep, remaining asleep, or even like sleep disorders as in sleep apnea or night terrors. All of these can actually happen during the time where women are transitioning through menopause, right? Skin and appendages, meaning women do lose collagen. The skin loses more collagen during the time where there's the perimenopause transition, and women notice that their hair might be thinning or falling more often than what they like. Their skin is becoming drier. Wrinkles are noted. All of these things, if they are not constitutional, meaning if that woman does not look like her parents, her aunts, her mom, her siblings, you want to look into how her ovarian aging is manifesting and start looking for lifestyle prescription. And there are products specifically for women in that age. Clinical scenario. Miss Diallo is 56-year-old African lady. She's G6 para 6, means she had 6 babies, 6 deliveries, coming in for her whole woman exam. She hasn't had a period for over 13 months as far as she recalls. She noticed that she has been sweating a lot lately. Her sleep is interrupted due to feeling hot when no one else is. She's worried that she may have thyroid issues. I'll mute myself, and I want you to tell me, what do you want to know about Miss Diallo? What questions do you want to ask?
I want to ask about her periods.
Sorry?
I want to ask
Periods?
about her periods. Yes.
Periods, yeah. The last period was 13 months ago. Her last menstrual period was 13.
Oh, I'm sorry. Yeah.
And prior to that, she said for 1 year and a half, her period changed, but she's so busy with her kids. She felt like it wasn't as regular as before for 1 year and a half before she missed it 13 months ago.
Doctor, she does mention that she's worried about her thyroid issues. Did she have thyroid disease before?
Excellent. No, she did not. She said she doesn't have, she's never been told that she has thyroid issues before. And her sisters has actually had some issues with her thyroid, but she's not sure if it was an overdrive or a hyperdrive.
I think because the clinical profile fits, that we shouldn't go like too far away with questioning and testing, especially FSH, because FSH is said to be like not reliable. So I think we have to start discussing expectations and life scenarios and life quality issues for the patient. Also giving advice regarding the condition.
So I usually try to always remind myself that history is 70% of a clinical evaluation, right? I want to know that patient. She already mentioned a couple of implicit goals. One, sleep sucks. And so two implicit problems: sleep is problem and feeling hot on and off. And then implicit question, could it be my thyroid, right? And then she gave me a hint that 13 months ago, her period is gone. So I want to learn a little bit more about this patient so I can draw a map in my mind. How can I best serve her long-term? My patient doctor relationship is longitudinal. I see them every 3 to 6 months if I was to start any treatment, or actually sometimes every 6 to 8 weeks when I start treatments. I see them every 3 months when I have a healthcare goal. I see them every 6 months when I just want to check in. And then I always push them to come every year for a wellness visit. So in order to provide that longitudinal relationship, what do you want to know about Ms. Diallo? You asked specifically about her current problem, like periods. You want to learn about periods. Some of you asked past medical history, what her thyroid, does she have history of thyroid problem? I don't know if you want to ask about any other, you know, like history of present illness, past medical history, surgical history, social history. What questions do you want?
Maybe I want to know about her relationship status or sexual activity status.
Excellent. So when I asked her, she said, I haven't been sexually active much because my husband is old and he has diabetes. Okay. So in the clinical evaluation, I want always to verify age. So I'll tell you something. In the United States, there are a lot of African refugees in general, African, Nepali, Mexican, a lot of them actually come in with no birth date. They come from cultures where there's no birth certificate and they don't necessarily have the accurate age. So I always verify age. So for those who may be practicing here at some point, BMI, how much she weighs, and her BMI, is it like at the higher level where I would be concerned for cardiovascular disease or cardiometabolic issues? Just in case, you know, she at some point needed hormonal replacement therapy, I want to know what kind of, is she a candidate, right? And I'll come to that slide in a second. When was her first period? How long has she had been exposed to periods? So sometimes women can come to you with heavy bleeding at 54, and they have been regular in their periods since they were 9, which means they have been having bleeding for 45 years. If they have not had babies, they are at huge risk for endometrial hyperplasia and endometrial cancer, right? As we know that unopposed estrogen, meaning no breaks for pregnancy or breastfeeding, places a woman at a risk factor for cancer. So I always want to have the clinical picture clear for me of what are her risk factors of being sick, all kinds of sick, and how does her hormonal profile impact it? That's like the whole person picture that you guys can provide as primary care providers. Last menstrual periods, she said, as far as she recalls, 13 months, right? And when I ask them, when they say, as far as I recall, I start asking them cultural points. So for instance, was it did you have one last Christmas, right? And we are now in December. And if I ask her if you had one last, oh, no, I'm sure it wasn't Thanksgiving, right? So that's 13 months. For people who, for instance, observe Ramadan. So did you fast 2 Ramadans? With no periods. So if they fasted 2 Ramadans with 2 periods, that's probably more than a year, right? So you try to identify the cultural context of your patient to better serve your history data gathering, right? Genitourinary syndrome or symptoms. In this case, is it a GSM, which is a genitourinary syndrome of menopause? She doesn't have sex. What questions do you want to ask otherwise? Any problems when you pee? Did you notice that it burns a lot? Have you had bladder infections in the past more often than before? Does it itch down there? Do you feel dry? Do you experience vaginal discharge? So it's not, the relationship is like the end result. But women can have vaginal or vulvar activity other than intercourse. So try to explore that to see if she has any symptoms or like pathologies that she's not necessarily recalling to share with you. You are a clinical investigator when you are doing encounters, right? Then another thing, she said she has sleep disturbances. You want to ask if this has happened before. Does she have any issues with breathing? You want to kind of look at if this is like a sleep disorder or sleep disturbances secondary to hormonal profile changes. So always try to ask key questions on each of these symptoms to direct your compass towards, oh, it looks like we're really dealing with menopause stuff, okay? Mood, cognition. Have you noticed that you've been more irritable, more sleepy, more lazy? You know, do you feel like you have been forgetting stuff? You know, dementia is almost 6 times in women than it is in men. So it's almost becoming like a disease of a woman. Just so you know, like when it comes to Alzheimer's specifically, not general dementia to be accurate. And I can provide numbers, inshallah. Past medical history. Have you ever been diagnosed with heart disease? Have you ever had any endocrine issues, thyroid, diabetes, parathyroid? Have you ever been diagnosed with any issues related to your glands, right? Or, you know, glands is probably a medical jargon, but mainly diabetes, thyroid issues, any other medical problems that you can recall of, any cancers in you personally. Have you been diagnosed with skin cancer, ovarian cancer? Have you ever been told that you have issues with your uterus? Sometimes they would tell you about fibroids that their gynecologist had diagnosed and they never followed up on it, right? Because it was small or it wasn't symptomatic. Have you had clots before? Blood clotting, gallbladder disease, because gallbladders are ones that process lipophilic hormonal replacement therapy. Anything that has impact on cholesterol kind of interferes with gallbladder. And also, if she had cholestasis of pregnancy, mashallah, she has 6 babies, 6 pregnancies. She's a grand multi, right? Liver disease, because liver would process any hormonal replacement therapy that you give. Also, if you were to prescribe non-hormonal options, some of them are hepatic dependent and some of them are not, right? So you want to look at if there's any liver disease to better prepare yourself to what options you have to manage that patient. Osteoporosis, has she been diagnosed with bone thinning or issues with her bones before? Has she had unexplained fractures? You want to investigate that as much as possible. Do you still have your uterus and ovaries or not? Do you drink alcohol? Do you smoke? Are you sexually active? And is it men or women? Nowadays, we have to ask that question, right? Family history, clotting, blood clots, cancer, thyroid issues, diabetes, whether it's type 1 or type 2, what menopausal age your family go through. Mom, sisters, aunts, and on an examination, I want to see blood pressure and I want to do a pelvic examination. That is fairly successful clinical encounter to map the management of your patient. So now that we have this, if you guys have a pen and a paper and you would like to take some notes, I can tell you, because I'm going to go back to ask you, how do you want to manage Miss Diallo? Okay, so she's 56. Her menarche was at 11 years of age. Her BMI is 34 and a half. Last menstrual period was 13 months ago. She fasted 2 Ramadans, but it was irregular period 1.5 years prior to that. She's not sexually active much because her husband is old. She didn't notice much change in vaginal discharge and no issues with peeing. She's a high school graduate, but owns her own market for traditional clothing. She's diabetic, controlled on metformin. No lab tests for 2 years because she did not have insurance. Her mood is okay, but she feels like she gets nervous faster and at little stuff compared to before the last year. She has not been sleeping well due to feeling hot for 2 months. Denies heart disease, blood clots, and does not know what osteoporosis is. She has not had any surgeries, and all 6 births were vaginal. She never smoked, but her husband used to smoke when they were younger, 12 years ago. Denies family history of cancer or blood clots. She thinks her mom has had her periods to her late 50s too. She has 1 sister who is younger, and all other siblings are brothers. Her blood pressure today is 127/80, and her heart rate is 82. Do you guys like me to repeat, or do you have any questions that you want to ask about Ms. Diallo? Okay. So,
Yes,
yeah.
please. Yeah, the first like 5 points, please. I'm sorry, but I missed them.
5 points I said about the patient, you mean?
Yes.
Yeah, so she is 56. Her menarche, which first period, was 11 years. Her BMI is 35 and a half, and the last menstrual period was 13 months ago.
Okay, thank you.
You're welcome. Candidates for hormonal replacement therapy. If you were to think at all, like you look at her and you're like, oh man, especially nowadays, by the way, there is a tendency in the modern world to think of healthcare as a good, as a merchandise. You buy your health. You have insurance, you can buy your health. You can buy tests, you can buy medications. So we think of the magic pill always. I don't want to do any lifestyle prescriptions. I have the right treatment for you. I'll give you some low dose transdermal estrogen. But you want to look at the patient as a whole, and before you suggest any management or discuss clinical treatment without doing your pelvic examination and do your dues by due diligence, gathering information and collecting history, is candidates are only those with moderate to severe VMS and GSM. Those should be affecting quality of life. You can use forms to gather information, quality of life, or you can look at the patient. If she's really distressed and she has come to you and she's just ready, like, I really need a solution now. I can't live like this. Right? They will give you clues that this is just negatively impacting their quality of life. To prevent bone loss and reduce fractures in postmenopausal women. I know that in previous slides that Dr. Mustafa has kindly prepared for me, this is actually an update in the guidelines. Osteoporosis and depression are promising if we start HRT early in postmenopausal or perimenopausal time, you can probably prevent depressive disorders and prevent osteoporosis in women. This is huge. Huge for someone who might live 40 years. Come on, Karim.
About the osteoporosis thing.
Yeah.
So the latest I have read was about that risk versus benefit. You do not use hormone replacement therapy for preventative causes, for preventative purposes, but you actually use it for treatment of symptoms, like for management of symptoms. I don't know about the efficacy. That's an outdated.
Yeah, that is outdated. Thank goodness that is outdated. Here are the reasons. Women are coming for wool exam more often. And then the one osteoporotic fracture, especially of the hip, can reduce life expectancy by 50%. Right?
What about bisphosphonates for osteoporosis?
So I think that you're talking about the pathology after it has happened. We're trying to prevent osteoporosis from happening. And HRT started within 10 years of menopause or perimenopause has been found to prevent bone loss. So you're preventing osteoporosis and osteoporotic fractures from happening. That's the update, that we are using HRT promisingly to prevent bone loss. And remember that the WHI anyway misguided us because all of their age group in their cohort or population studies were 60 plus. Right? There's that perimenopause. If you look back at the workshop stages, there's that 10 years. That's the golden years, right? With the ovarian aging contributing to compounding somatic aging leading to osteoporosis, especially for women who have used their bones to carry many babies. They don't have enough protection. The main player in their reproductive age group was progesterone, right? It's progestin. So the estrogen protective effect of the bones is not there. That's why, like, you know, women in the past used to say, like, with every pregnancy, I threw a tooth. Right?
That's a great point.
Sorry?
Sorry, I was saying that's a great point about the progesterone being the dominant in their life, the dominant hormone in their life.
Yes, yes. And that's why, you know, like maternal morbidity and mortality, that's what actually killed women early. We didn't have to deal with the menopausal impact as much. We have to look at how our demographics are changing due to contemporary interventions, right? And our environments are different. My husband's mother, she's a mom of 12 with 4 miscarriages. So technically she's G16. My paternal grandmother, she's G14. Right? My great grandmother, she's G18. I can't imagine what their bodies has been going through, but all of them had osteoporosis. All of them had issues with their hips, either being weaker, and that really reduced their quality of life towards the end of it. Right? We're not really trying to make sure that women live forever, but in that 10 years, if we can prevent osteoporosis and osteoporotic fractures, that's a huge victory to the cost effectiveness of women's health. And remember, like, it all circles back to the dollar. It's not like they really care for women as much. Unfortunately, we want to develop that. We want actually, that's why I love NABS, because it's all women for women. And we're truly looking at women within that 10 years period of time. And they are collecting all the guidelines, and there's, you know, intersocietal collaboration, and there's no like call like let's give HRT to everyone, right? There are women, mashallah, the African-American women here, mashallah, like their bones are excellent, and they have periods up to 56 and 57 that are regular. And if they had multiple babies during the time, that's very healthy. They start having babies young, they have periods longer, and they tend to be exposed to the sun more. Even though the darker skin is actually harder to absorb vitamin D, yet they tend to do better bone wise. So if we diversify population, we can identify what are the protective factors for African women, American women, beyond just having longer exposure to estrogen or like longer or a deeper reserve of that. But for now, the candidates, I would look at you. And if you are like a woman who lives between the 23 and between the 20 and 25 BMI, and you know, like you are dairy, like personally, I'm dairy free, I don't do any dairy, and covered, you don't get exposed to the sun, and if you get, you don't really have large surface area where you can acquire vitamin D post puberty, you're a good candidate for HRT if you have your menopause around like 51, between 49 and 53, right? You will have like a 10 years before you're 60, you are a good candidate for an HRT. That would protect you, especially if they have bones, aches, issues, and not necessarily having adequate calcium and vitamin D. That's a huge progress, I think, in the clinical provision, right? Using that for prevention. But I agree with you, Kareem. We are always have to use reservation, be conservative, that we are really learning that doing less to women is doing more. That is why the new updated guidelines, which is so exciting, which is a tangent, sorry to bring that in, but now cervical cancer screening is going to start from 25 years instead of 21. This is the most recent 2020 guidelines. I'm very, 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 very excited because I've always actually marketed for that. Like we're really starting too early being invasive to women. But this one is definitely from direct clinical interactions. This will be a great service for women if we identify candidates properly, right? So young women with hypogonadism, primary ovarian insufficiency, premature surgical menopause without contraindication. I cannot tell you how many times I have met women who have had their ovaries and uterus removed, especially those that are BRCA positive or have, you know, like breast cancer that is ER positive. They tend to have like their ovaries and uterus removed, and never once somebody canceled them for osteoporosis protection. I think this is sad, honestly. This is like a failure in clinical provision. So hormonal replacement therapy is recommended when the average age of menopause is less than 10 years of last menstrual period or less than 60 years of age. And I think that would change. The longer women live, our age bias will change. Contraindications, the absolute one is active breast cancer. Currently, she has breast cancer for which she's being treated, active endometrial cancer, active clot, myocardial infarct, which is an active clot in the myocardial tissue, and pregnancy, of course, right? Relative contraindication, which could be confounded, is history of stroke. She had a stroke before, or any kind of clots. History of breast cancer, which I had a couple of my patients who had been ER positive on tamoxifen and experiencing hot flashes. I can always talk to them about treatment. Doesn't have to be HRT, but they can be candidates for HRT if their quality of life is severely impacted. So don't shy away from being eccentric if you are providing the service. And we're going to talk about like duration of use in a second. If they have risk factors of coronary heart disease or risk factor of endometrial cancer like obesity or smoking or lack of progesterone break, like they are nulliparous, did not have babies. Management planning, always remember you're treating a whole person, individualized. You're not treating data, you're not treating clinical research, you're not treating a population, and you're not treating only a symptom. You have to see the person from a bio-psycho-social spiritual model. So topical for isolated and local symptoms. So always think, if I have GSM, I can target topical, so minimize systematic. Always move from oral, transdermal to systematic, or to treating constitutional symptoms. So the oral is for systematic, transdermal or topical or local for topical or local symptoms. Almost all systematic hormonal therapy products are approved for vasomotor symptom relief. That's where they actually prove themselves clinically effective. There's something called CER, which is a clinical effective research. It's not just, it's really focusing on one symptom at a time, and then hopefully we can have like a translational research where it's patient-centered. Primary menopause-related indication for progesterone use, there's endometrial protection. If there's no uterus, you don't need to think of progesterone containing, because progesterone, think about it, it's progestin. it can give you symptoms of pregnancy. That's why women kind of complain sometimes when even start OCPs like, oh, I have been bloated or feeling nauseated. So you always, the symptom that is reported as a side effect tells you which hormonal preparation you want to use. So understanding your basic science is pivotal in addressing endocrine issues specifically related to women's hormonal profile. Am I making sense or moving too fast? I see thumbs up.
I think, yeah.
Okay. Progesterone generally is not indicated with low dose ET for vaginal atrophy. So like if you were to use it topical, you really don't need progesterone in there. It doesn't necessarily give you that proliferative effect and nice like cushion of that mucosal tissue. Transdermal one usually are lower risk of DVT, stroke, or MI, even though they are systematic. But because they are bypassing the hepatic pathway, they are delivered in lower doses and they are directly impacting the effect that you want to treat. Compounded hormonal therapy is not FDA approved. So non-bioidentical one are not FDA approved. Do not recommend them. Do not endorse them. Do not market them if you have a private practice. Please do not do that. They have been under research multiple times, and the harms due to potential contamination with other ingredients can outweigh the benefits. Hormonal replacement therapy directly helped multiple endocrine issues or like improved response of other endocrine glands. In this case, it's diabetes, weight, which I think the adrenal gland is a huge part of it, sexual health, urge incontinence, so that improved by buffering and giving a good cushion to the vaginal tissue. HRT should not be recommended as an antidepressant, but it was found to prevent depression if it was to be started in that 10 years. So it doesn't have an antidepressant effect, but it can improve the potential of developing mood disorders if it was to be started timely. And that is my passion towards having primary care, being educated about menopause, is that a woman can meet a doctor at the right time, at the right place, whenever she knocks the door. And that's why primary care physicians, whether you are internist, whether you are an OBGYN, whether you are a family physician, you really need to have some basic knowledge on where to adhere to when it comes to menopausal symptoms. It is not recommended at any age for preventing or treating cognitive aging or dementia as of yet, even though it was found that women are more likely to develop dementia or cognitive dysfunction post-menopausal. We cannot really claim that HRT is helping with that. We didn't identify the equation necessary for it. This is actually from an Ireland document, so you may notice that the names are not necessarily in English, but I really like it. If always when you look, oh, I want to start an HRT, or actually I think you are a good candidate for hormonal replacement therapy, I would always want to ask, do you have a uterus or not? Or the uterus is muted or not? Do you have a marina in there? Meaning, is that endometrial lining stable or not? Do I have to worry about it being proliferated? If yes, then you think estrogen only. There's no point of exposing the body to progesterone with potential side effect when there's no benefit therapeutic. And then you ask yourself, if they still have their uterus in there, then you have to have an EPT, which is estrogen progesterone therapy. And then you look at the last menstrual period, because combined OCPs or combined hormonal replacement therapy has indications other than contraception, right? But you still can use the same formularies with the lowest dose potentially possible for menopause, and then start increasing the doses. If the last menstrual period has been less than 1 year, you're actually looking at more of a contraceptive effect. So treat it as if you're doing contraception. Even if they're symptomatic, you can actually offer something like this. And then look at individualized. Are they able to remember to take a pill every day? Would they rather have like a patch? Would they rather have a vaginal ring? Multiple options are there to help treating these symptoms. Up to this moment, patches and oral are very helpful. And then you're looking at risk factors. Are they at increased risk of VTE or stroke? Are they actually obese? And if then yes, you are actually bypassing the hepatic side. Always helps to bypass the liver when it's overwhelmed with potentially storing fat for patients, right? Otherwise, you actually do not want to give them bleeding. If they have had a break from feminine hygiene products, that's awesome. Okay, do not make them bleed. So go into continuous HRT where they can actually continue to have that break, and aiming for vasomotor relief or prevention of osteoporosis or improving lifestyle, depending if their symptoms are local or constitutional. Same thing with the estrogen here. You can actually look at same risk factors. Are they at increased risk factors for VTE, or are they obese? If yes, always bypass the liver. It's not really difficult. If you guys remember these visual algorithms, you will have more courage to discuss pros and cons and be deliberative in delivering treatment options to your patients. And thanks to Dr. Mustafa, I kind of made some modifications, but I really appreciate the nice artistic effects of that. So I just want to give you the credit for preparing this slide. Thank you so much for that. The treatment of vasomotor symptoms can be hormonal or non-hormonal. And honestly, like the non-hormonal, I'll tell you this, okay, hopefully you wouldn't judge me, but if I get the chance to put SSRIs to our, like, put it في المية, you know, for people to drink it, put it in, especially after all the trauma that the world has been through, that would be really awesome, just to kind of improve if it wasn't just for ethical and fertility reasons. I think everybody needs some serotonin reuptake inhibitors, or a lot of dark chocolate, I guess. Everybody is traumatized. So I think SSRIs, I'll tell you something I counsel my patients with regarding the SSRIs. I don't tell people it's antidepressants anymore. You know, I love basic sciences. You know, like if I didn't go to family medicine or primary care where I can take the patient as a whole, I probably would have done basic sciences. Honestly, SSRIs are not just antidepressants. Well, SNRIs as well. I call them in Arabic حافظات النواقل العصبية. They preserve our neurotransmitters. And a lot of times when people are so overwhelmed, so many changes in life, we break down those faster. We consume these good, happy hormones and neurotransmitters, and then the brain cannot really take it. And then cognition and mood and all of the nervous system, whether it's central, peripheral, or autonomic, gets impacted negatively by the drainage of the serotonin. So I don't call them antidepressants anymore. I call them happy hormone preservatives. So I tell women that these are good options. They're not addictive. And if you don't want to use hormonal therapy, let's try a very low dose of this and go on it, right? And you know, this is the time to use Paxil. I don't like Paxil in reproductive age group because it's category X. And if there's a chance that this woman can get pregnant, there are like a huge list of SSRIs. So don't use Paxil if the woman has any minute chance of getting pregnant. Please do me a favor. And another thing, like Paxil really does take time to leave your body, right? So it does leave I think that's why some psychiatrists use it, because even if you decide, yes, Karim.
Sorry, use what?
Paroxetine, I meant. Sorry, I used I apologize. The generic name is paroxetine, but we call it here Paxil. Probably has different names, I'm aware. But paroxetine or Paxil is one that is category X in reproductive women. And it's the only one. The other SSRIs are between category C and category C with consensus being B, because it's used a lot, right? Women in the Western society are much easier in accepting medications to resolve their issues, because we really have no options to take a break. In our lifestyle here, there's no option to take a break. So if you have like, if your life course is bumpy and it was a roller coaster for you and there's a lot of traumas in your life, it's easier for you to utilize sometimes these magic pills to preserve your serotonin in the middle of doing gazillion things in life, right? Nonetheless, for hormonal, systematic hormonal therapy, it can be either transdermal or oral. It can be pretty much local. And you know, the WHI study pretty much suggests that postmenopausal estrogen and progesterone could have had increased coronary disease, but luckily the evidence shows that they could reduce that risk if they are used within the 10 years of the LMP, which is the last menstrual period, right? And the initial research on menopausal hormonal therapy continues to be promising. As you can see, we are now able to prevent even the to prevent, like, osteoporosis in general, right? Alternative therapies, believe it or not, there is some hope as well. So Ayurvedic, have you guys heard about Ayurvedic medicine? Ayurvedic medicine is like an ancient medicine based in the Indo-Pak or Desi community, mainly in India. And it treats the whole person as like a combination of 5 ingredients, wind, earth, fire, and a couple of other things. And then the theory of Ayurveda that each being has at least 2 predominant components to which they screen you, they decide and define what things works for you. The thing that I have to say to you guys, if any of you is interested in complementary, integrative, or alternative homeopathic therapies, the scientific research methodologies we use for traditional and conventional medicine should not apply to these therapies. بمعنى, cross-sectional, observational, or retrospective, or prospective study design, or methodologies, or surveys cannot necessarily apply to homeotherapies. That is why we are failing in integrating and introducing alternative therapy to the field. But I think that there's a progress in that. Nonetheless, I have to agree that none of the things suggested, like, good job, Mariam, thank you. There's nothing like acupuncture, yoga, even over-the-counter estrovens and all of these preparations. They are not found to help with menopausal symptoms, right? There's not significant nor sufficient evidence that can support those to be a prescription. So what I do is I be informed information. I never ridicule or dismiss a patient who's using alternative therapy. I'm just very cautious about, like, oh, there's no harm, it's an herb. Actually, there could be harms. Some of herbs, like, for instance, in our culture, we know that الحلبة, القرفة, الحلبة, الfenugreek, القرفة, cinnamon, sage, maramia, all these 3, for instance, they've been really documented even in ancient sciences that they have impact on certain hormones. So that concept of مش هيضر تاخدي زيت تاخدي خروع تاخدي, it's not going to harm you, this is not really accurate. And that's not how I would like clinical scientists to deliver themselves. I would remain neutral and informational and rather be more deliberative in discussing what we know to have sufficient evidence. But that doesn't disqualify these alternative therapies as of yet. We just need to find the right methodologies to evaluate them. So for instance, I did notice that you guys want to learn about details, and I'm happy to share the PDF with all of those who have attended. But as you can see, the conjugated estrogen, micronized, transdermal, conjugated estrogen with a SERM, which is bisdoxifene, which is a selective estrogen receptor modifier. This is not a hormonal one. This is one that improves the access of the hormone into the receptor, right? Those can be used for synergizing and improving receptor sensitization to estrogen. And those are actually good when you have a uterus in, and they are really awesome. I think the name of one is Duafi. Oh, here it is. Oh, sorry. I use that often, honestly, for patients who do not like the progesterone impact. And this can also protect the progesterone lining. So here's one thing I would actually recommend. Our learning curve should be accumulative. You can't really absorb all of this information at once. And medications always have updated profile. So while it's really nice for you to have an idea, what I would recommend for you to become really solid clinical scientists, not easily fooled by pharmaceutical companies, learn about what conjugated means, what micronized means, because as you can see, like the micronized dosage can actually be a little bit higher than the conjugated one, right? It's not as potent, but yet it's actually like more of prepared for the receptors to utilize them. Understand the difference between the type of hormones we use in hormonal replacement therapy and one in the contraceptives. So in the contraceptive ones are better calculated. Why? Because we know that we are trying to prevent pregnancy. So you can't rely on natural sources like ethinyl estradiol. Ethinyl estradiol is usually natural one. The bioavailability of it differs from an individual to the other. But the estradiols it's the other way around. The estradiols are naturally happening, and you cannot really calculate how much of those are changing based on the individual. So my metabolism of estradiol is different than my sister's, my mom's, my aunt. But ethinyl estradiol, or the type of estrogen used for contraceptive, has more solid studies on how much of that gets delivered, because we are really trying to provide sincere service, promising our patients that that would be a good family planning or reliable family planning tool. So for me, I always look at, oh, okay, so why pharmaceuticals doing this, and what's the difference between conjugated and micronized, and what's the difference between ethinyl estradiol and estradiol, and you build on your knowledge and understanding which one you want to prescribe to your patient. So if they are still like less than 1 year last menstrual period, do you really want to regulate their bleeding? And that makes you think, okay, like maybe let's use something more reliable when it comes to bioavailability. And patients just love you, right? Because they have been to multiple OBGYNs and none of the formulations work. So while obstetricians and gynecologists keep telling us they are all the same, with all due respect, I respectfully disagree. They have some differences. The northindrone is different than the drospinerone. Some has less estrogenic, less progesterone impact or effect than the other. One has less bloating, one has less swelling, one has less edema. So you look at what kind of side effects your patient has, and you start building your knowledge. And always believe your patient. If they're telling you, like, I don't like this OCD, the other one was better, look at the differences, and how that's how you develop your knowledge, and your patient becomes your teacher as well. Treatment options for GSM. We can use, Premarin is extremely expensive, which is really annoying. Here I'm ranting about women's health. Everything for women is more expensive in the West. So the blue pill or the Viagra for a man is much cheaper than it is for a woman to get a Premarin cream, even though it improves quality of life, reduces urinary infection, reduces potential itching and vulvar injury, yet we consider like, oh, you don't need sexuality. It's not really just merely about sexual health. Okay, so vaginal cream, and a lot of times women actually use it less than prescribed often. One reason is because it's expensive. They don't want to use the whole tube in a short period of time. And actually they get the impact very well. I think we don't have enough studies on that, because women's follow-up after starting the cream becomes interrupted because they've achieved the therapeutic goal. But we have the estrase or vaginal cream. The prescription can be always like a difficulty. So just try to remember that you have to prescribe it in grams, and how to apply, how often. You can do it gradually, or you can actually start on a daily basis, or even start from the beginning gradually, depending on how severe your woman's symptoms are. So you can consider that most of the topicals should have like a loading dose. You use it daily, and then maintenance dose. So that's how you want to explain it to your patient. ماشي، احنا هنبتدي ناخدها كل يوم لمدة أسبوع علشان ايه، نعمل فخامة بقى في الفاجينال، في البطانة بتاعت المهبل، وتاخديها بمدة أسبوعين مثلا أو أسبوع بالكتير، وبعديها تاخديها 2 times a week أو 3 times a week. تمام؟ فهم if they actually know, if you share that plan with them, they're more likely to comply. ما بتديش وصفة مكتوبة. And sometimes answering to the why، يعني اشمعنى اخدها بقى كل يوم اول اسبوع بعدين اخدها مرتين، انت عايز تضحك عليا، مش عايز تبكيني. Patients really want to understand. So educate so you can guarantee better compliance rates. تمام؟ Interestingly, Ospina or Espimphin is one of the medications that are new. I'm so excited. And I love all the updates to Made to Women's Health. But this is an oral medication that is used for topical impact. It was found to improve the thickness of the vaginal, and it doesn't necessarily have any negative impact on the hormonal profile or increasing estrogen or progesterone. تمام؟ طبعا it's important to know انه على فكره you can recommend at the beginning non-hormonal options، يعني moisturizers، حتى coconut oil, by the way, coconut oil and olive oil and water-based gels. All of them were found to improve the vaginal symptoms, especially for sexual health. So you don't have to start HRT, but most of the time, believe it or not, women have come after they have used oils, right? Because there's Dr. Google always helping us in starting the initial treatment, and they come for the prescription capacity of your MD degree. And if you teach them well, they will come back to you and they will teach you of what has happened to their body. So always teach, always teach. Okay. Thank you يا مصطفى. I'll move faster. تقولوا لي بس لو زهقنا. تمام. So I think I kind of talked about these points. So أنا مش عايزة أكمل بعد. I agree. تمام. طيب. I can share the slides. I think that I've talked almost about all of these things. Last point I want to talk about is that you can prescribe these hormonal replacement therapy for at least 3 years before you start discussing discontinuation. Tamam? There is not much solid evidence that you should stop them 100%. So after 3 to 5 years of actually sharing that or prescribing the hormonal replacement therapy, 50% of the vasomotor symptoms may recur, but you have treated 50% of the population. Symptoms recurrence similar whether tapered or abruptly discontinued. So the patient prefers to stop it, she's concerned, she read something, she doesn't want to do that, you can drop that, right? And if they have no increase in any kind of cardiometabolic risk factors, which is the top killer now of women postmenopausal age, you can have a shared decision making. So if there are no contraindications for continuation, you don't have to stop it unless patient preferences as such. New areas that there's no evidence for Beer's criteria, which is responsible for geriatric prescriptions, that after 65 you have to stop it. There's no an absolute contraindication to stop it. Breast cancer risk does not increase appreciably with short-term use of EPT, which is estrogen progesterone therapy. And there's no increased risk of breast cancer in women who are BRCA positive even on hormonal replacement therapy. Opening it to questions.
We have one question here from Kareem. He's asking, what about when used for prophylaxis? I don't know.
If you mean prevention or prophylaxis of hormonal, vasomotor symptoms?
No, we spoke about prevention of osteoporosis. So how much time should I keep the patient on hormonal replacement therapy?
That's a very good point. In this case, I would actually look at the same contraindications for it. So if I'm using it for preventing osteoporosis, this could never be the only indication for using HRT, by the way. Right? Preventing osteoporosis can be as simply as using therapeutic vitamin D and adequate calcium dose. And for those of you who may not be up to date to that, calcium dose is 1,200 milligrams for women postmenopausal, and it has to have 1,000 units of international vitamin D. These are the two doses recommended for women postmenopausal. Of course, nowadays, for us, for instance, in the Midwest, where we have 3 months, I tell women to increase to at least 2,000 units international units of vitamin D to be protected, right? Especially that vitamin D does not get preserved for so long. Its a lifetime is 90 days, which is the 3 months of winter when most women kind of drop down. So you can't just use HRT for prophylaxis of osteoporosis as a sole indication, right? If a woman is prone for osteoporosis, BMI 23, 25, she's not a smoker, her period time is uninterrupted, she had her menarche at 12, her last period is her period changes started at 48, 47, and she doesn't like dairy, and she doesn't really eat much green leaves, which is high in calcium and vitamin D, and she's having some vasomotor symptoms, she will be like, okay, let's talk about this. Did you consider that? And then HRT, by the way, is not only hormonal replacement therapy. You can use contraceptives. So once you offer therapeutic dose of estrogen, you have actually provided prophylaxis to osteoporosis. And then you ask me how long, it's the same thing, 3 to 5 years, and you reevaluate.
Okay. So regarding our specific patient, the one we talked about earlier,
Yeah.
She has a BMI of 36, as a
34 and a
35.5.
half. 34 and a
Yeah,
half.
34 and a half. She's diabetic. I actually want a lipid profile for this patient to continue my evaluation for cardiovascular disease before
Excellent.
using hormonal replacement therapy. And I will actually want to use SSRIs, like a trial, because she's diabetic, she has a high BMI, she's at higher risk for cardiovascular disease.
But Dr. Karim, I still think that I may have thyroid issues. I'm really concerned because my sister said she had thyroid issues and she had issues with her feeling hot and she was not really able to sleep. I don't want to take any medications before I know if I have any issues.
Okay, for this specific question, I can do like more patient education about the symptomatology, and that she is unlikely to have thyroid issues. She's more likely to have this because ABC. In the end, if she's not content with my answer, we can do the labs for thyroid, but not in the beginning.
But I haven't had labs for 2 years because I didn't have insurance. And I have been taking the metformin for almost 10 years now. And they told me like 2 years ago that my diabetes is controlled.
So no recent labs for diabetes?
I haven't done any blood work. I haven't seen a doctor for 2 years because I don't have any insurance.
So this patient, even this patient has to have diabetes workup also. She may not even be controlled.
Okay, that's good. So what do you want to do?
Does she currently have insurance?
She does. I do have insurance now, Dr. Karim. That's why I came to see you.
Okay, I want to check for diabetes. I want to do like a random blood sugar, and like accordingly we can do fasting blood sugar, blood glucose. I also want a lipid profile for cardiovascular disease assessment. Okay, and we can start looking at her symptoms. See if she is content with my education regarding the thyroid issue. If she's not content, I think we can do thyroid profile.
Okay.
Like TSH.
Okay. Okay, so I had my breakfast this morning and I came. Does that matter what kind of blood work you want to do? So somebody now, does Dr. Karim wants to do fasting blood sugar, lipid panel, and a TSH. Anybody else would like to add to that labs?
I may be
She doesn't
wrong.
have a ride. She's coming with her neighbor. So if she's going to go to the labs, she wants to go once.
Yeah, I may be wrong, but I want to do a random blood glucose first before doing fasting blood glucose.
Can we do the A1C?
Yes, of course.
Yes, I agree.
ما حدش عايز يعالج مس دياله غير كريم يا جماعة.
I want to do hemoglobin.
Okay, so hemoglobin A1C.
Yep.
أنا هبتدي أحول لك على فكرة يا دكتور كريم. You have a huge passion towards patients. The other doctors, they don't want to take Miss Diallo. So they don't want to do anything. They don't want anything to do with women. So.
شكرا.
Anything else that you guys want to do to this patient? She is on metformin for 10 years. She's been having sleeping disturbances and hot flashes. Feeling a little bit more nervous, positive plus minus thyroid issues that is not confirmed in the family. And she has one risk factor or two maybe, so passive smoking, but it's been 12 years ago. Her husband apparently had smoking cessation, but her BMI is 40, 34 and a half, and controlled diabetes. Meh, you know, it's not really like a cardiometabolic risk factor for as long as it was controlled for years. But then because of the BMI, Dr. Karim wants to get a lipid panel. And of course, because of underlying diabetes, A1C and lipid panel, and family history of thyroid, you want to get a TSH. What else can cause sleep disturbances and dysregulation of temperature?
When the patient is obese, so obstructive sleep apnea.
Okay, so I want to ask more questions, right? Tell me more about your sleep hygiene. I don't snore. My husband snores a lot, but I don't snore. I actually crash, doctor. I have 6 kids and all of them are at home. By 10, I am exhausted. But when I put myself to sleep, I feel so hot and I sweat a lot. But I don't snore and I don't feel choked. And my husband doesn't wake up to notice anything. He sleeps and snores and makes my life much harder. So when I asked her, do you sleep in the same room? And does the snoring of your husband bothers you? She said, yes, we do sleep in the same room, but he's been snoring for years and I got used to it. But lately, what has been really, really bothering me is that sweating at night.
So these are menopausal symptoms, hot flashes.
Oh, yeah, potentially.
Potentially.
What else do you want to know about this patient? She said she didn't have any surgeries. So she still had uterus and ovaries. Maria.
Does she take any other medications other than for diabetes and
Yes, Salam. Exactly. Nobody asked about medications. Exactly. Excellent. So she said that her daughter once heard that she has to take calcium and vitamin D. So she sometimes takes vitamin D, but not regularly, and she doesn't know the dose. And excellent, Mustafa, excellent. She doesn't drink coffee, but she drinks a lot of tea. And she likes, she likes the Somali tea. So she drinks a lot of it with milk. She denies any issues with her diabetes. She has been on the metformin for so long, and every time she goes to the doctor, they do a finger stick thing and they tell her that her A1C is good. The last time it was checked, it was 6.8, 2 years back. She doesn't like to take medications. She doesn't take any kind of medications, but the vitamin D that her daughter forces her to take. And she doesn't take any herbal preparations beyond the Somali tea that she makes at home. And she was not prescribed anything for high blood pressure before, and she was never told that she has hypertension. And one time the doctor told her she needs to be on blood cholesterol lowering medication because she's diabetic, but she does not like to take medications much. And her sister is taking metformin, so she's taking metformin because the family does well on that medication.
Okay, so I digress, but about this specific patient, because I am like a huge fan of statins. Like I am.
You should be, right? They changed the face of cardiovascular disease.
Yes, we should.
Yes.
We should give them to people in the street. So I can, like, we have to spend real time with this patient, convincing her to try statins. Like, just take a try.
See, the thing is, providing statins for patients who are diabetic is under investigations now, right? I think that as the lipid panel guidelines have changed, maybe because we have changed the map and the demographics of the people, The statins, you remember the aspirin at some point was like, oh man, primary prevention. At 45, you start taking aspirin, even if you don't have any issues. Now it's rest in peace, aspirin. You're not allowed to be taken for primary prevention because the risks are outweighing the benefits. And I think that is due to statins, right? To controlling the atherosclerosis. Aspirin, it has caused more side effects than benefits when it's given for primary prevention. So aspirin is only now popular as secondary prevention after stroke or cardiac illness. Now, when it comes to statins, I think they are awesome with truncal obesity. But for women with, like different fat distribution, I am really waiting for the science to give us different recommendations, right? And also like how much statins do really impact hepatosteatosis or fatty liver. I'm really interested in that. And I did notice that metformin does seem to cause more diarrhea in women who have fatty liver presentation on ultrasound. So I really hope that, if you were really passionate, Karim, maybe do your best to join research related to statins' role in people who have fatty liver, because this is underrated as well. Nonetheless, I agree with you. I want to know why a diabetic patient for 10 years who's not in statins, right? So I want to spend some time understanding what is going on with her liver, right? Is there any chance that she could have fatty liver? Is there a way that her liver would be able to process HRT? I was trying not to give you many hints, but I'm so glad that you picked up on that. Perfect. So she's not on statins, and I'm telling you, there's a doctor who was trying to convince her taking another thing for her cholesterol, but she said, I have diabetes only. I'm taking diabetes medications only.
Doc, do we know her blood pressure? I mean, she has cholesterol and she has diabetes.
Yeah, she was never told she has blood pressure issues, and in the clinic, it was 122/68 today. If I recall well, I think I can go back to.
Yes, I have recorded it. It was like 127/80.
Perfect. Yeah, it was normal when she came to the clinic. Most of the time it was normal for her. What else do you want to know about Ms. Diallo?
I don't know. I want to know how could she be more compliant to her medications? I mean, even
you need to befriend her, right? Medical advice and nasiha الطبية cannot be taken unless a patient trusts you, and trust needs to be built. That's why I love primary care, longitudinal relationship. Yeah. You have only, like, mashallah, you guys have marketed for this in groups that has so many people, but who's attending? The marvelous 8 to 10 people, right? The people who are really maybe interested in menopause, right? If you are as invested and interested in your patient, eventually you can get them to deliberately make an informed choice. She's not informed. She doesn't know why she has to take statins. The doctor told her you have to take statins because that's what the science tells us, not that what your body needs. There's a huge difference when patient interest is your priority versus implementing clinical guidelines.
Doctor, what are some of your favorite? Okay.
Yeah.
Should I speak or is someone speaking? Okay. On this note, I have noticed, like, because I currently live in Egypt, and like clinical advice is usually just do 1, 2, 3. So
yeah,
I
it's
have
parental model. It's called parental model, صح? It's a parental model. يعني أنا بقول لك وأنت تسمع الكلام زي بابا وماما.
So I have noticed a trend, like patients many times just take the advice and leave the clinic. They do not follow it. And if you just give them advice, like just tell them why. If you provide sufficient patient education, it dramatically increases their compliance, like dramatically. This is why I keep saying, like, patient education. It does have magical effects.
100%. يا كريم قول لي العيادة بتاعتك فين؟ أنا لازم أبعت لك I need your address. لازم نبعت لك patients in Egypt. That's exactly the key, by the way, and it's not necessarily any better in the Western world. يعني everything is sacrificed for the sake of expediency and making more encounters and more money. That's not my value system or my moral system. That's not my work ethics, and I hope that it's not yours either. فاحنا لما نشتغل مع المريض we are always thinking patient comes first. And sometimes, by the way, you have to take the clinical guidelines with a grain of salt. Yes, research is advanced. Yes, research methodology is actually mostly accurate. There's no 100% truth in medicine. There's always limitation to our science. So I always use deliberative model, meaning I present information with the intent to discuss it with patients. There are three models of patient education. There's parental, there's informative, there's deliberative. Parental يعني خد واسمع الكلام. Informative يعني I'm sharing information and I can't really encourage you to use one or the other because there's either insufficient data or I personally do not know. I am not up to date. There's the deliberative. I know it, I've experienced it, I consent to it or I do not consent to it. So if I strongly feel about it, then I use deliberative model. I bring the information to the patient and I discuss with them enough until they make the informed choice, which the medicine at that moment believes is the healthiest option.
I believe if you ask the patients what complications are they experiencing using these medications, is going to be, it will make them feel heard or understood, and maybe change the medication choice, help encourage them to start a new plan.
100%. Most of the time metformin الناس تديهم metformin and they never come back. Oh, اداني اسهال, I'm so like my GI upset, nausea, diarrhea, I can't, you hate me, why did you give me this medication? So also discussing potential common side effects with patients beforehand so they wouldn't be like, oh my gosh, they tried to poison me, is always helpful. Information, education makes a huge difference. And always with patients who haven't had like a longitudinal, well-established relationship with physicians, it is really of a sense to respect their ability to receive large amounts of information. Bring them back. Be the incubator. So شوية شوية, like piece meals at a time. مش كل المعلومات مع بعض. يعني عايز أعمل لك blood work وحضيف statins ولازم تكوني على أفرن ولازم ترجعي تاني عشان نعمل الفحوصات ولازم تعملي الفحوصات when you are fast. حبة. One piece at a time and prioritize what step I need to do to make sure that my patient doesn't die when she leaves the clinic. What is the highest morbidity and mortality on the list of pathologies that I need to address now? And that would kind of organize your management plan and be sincere in telling your patient to come back, right? So what are you concerned about? Hey, okay, مش بتنام كويس, she's not sleeping well, and she's having hot flashes, but the blood pressure is controlled, and there's nothing else concerning, but what is the top thing that can kill this patient if we don't address it?
The diabetes.
That's it. It's diabetes, right? That's what I want to focus. هي جاية بأجندة because that's what's bothering her. But I know more than she does. صح? I know more than she does, right? زي لما مثلا يجي your son من باص المدرسة ويقول لك إنه it was really stinky, it smelled bad, I didn't like the smell, I'm nauseous. You shouldn't ask, oh, I'm so sorry that you're nauseous. My question would be, why do you have smoke in your bus? Oh, the bus driver was smoking. This is actually what I need to treat.
Yes,
Not
I'm
your
sorry.
first, yeah.
So I'm sorry for interruption. I
No
do it
problem.
a lot, but like it just came to me like a light bulb. I remember. I want microalbuminuria for this patient.
يا سلام. يعني أنا كنت, thank you. She doesn't have any DSM issues, but in my mind, when I asked about sexual health, always my women, by the way, the moment they come to the clinic, they always have to provide a urine sample for real women exam. I tell them this is the golden water. You're not coming into don't pee before you come. I actually counsel them, do not pee before you come. You're going to pee in the clinic. You're going to give me that golden water because I can use it for so many things for postmenopausal women. So that's actually a smart idea and it's always overlooked. It's an early detection for potential kidney leak. Excellent.
Yes.
So you want microalbumin.
If I correctly remember, even well-controlled diabetes mellitus may have vascular effects. I don't remember if it's the macrovascular or the microvascular. I think microvascular, like well controlling does not prevent microvascular complications of diabetes.
Um, so I am not really sure.
See, I'm not sure if it's macrovascular or microvascular, but
I
one
will,
of them is not is not protected by with controlling diabetes.
yeah, so it is, so the urine microalbuminuria is for the glomerular vasculature, right? The capillary bit. This is a microvascular impact, right? But I do believe that tight control of diabetes that is consistent longitudinally can really protect you from further complications. Nonetheless, controlled diabetes doesn't necessarily mean that microvascular complications may not happen. That's why the microalbuminuria is more reliable than getting a BMP. The blood creatinine or serum creatinine bun. Omar, you have a question. It might have been answered. Do we need it, or is it recommended to have a DIXA scan that shows osteopenia before prescribing HRT, or is it just as long as the patient can afford and meets clinical criteria to be started on HRT? Would it be enough to go ahead and start them? It's B. So if they meet clinical criteria and they can benefit from HRT to protect them from osteoporosis, meaning they are a candidate for HRT due to other symptoms and they are at risk for osteoporosis, I will suggest HRT as a route to prevent osteoporosis from happening. So the DIXA scan is one that we recommend after 65. Their DIXA scan will not be covered by insurance unless there's an indication for it. So remember that in our sphere, of course, if you're practicing outside a healthcare system that is governed by health insurance, you probably can order a DIXA scan, just send them to radiology lab. But here, you cannot get that code passed for someone who's younger than 65 unless you are saying at risk of osteoporosis, like people who are on prolonged steroid treatment, like rheumatoid arthritis or one of those autoimmune diseases, or if they are chronic smokers and they are underweight, which happens, quite more often than I would think to have underweight people in the Western community. And, or if, they have osteoporosis, if they are underweight and have had female athletic triad or premature ovarian insufficiency, usually you have to have a clinical indication to do a DIXA scan beyond just screening for osteopenia. It doesn't get covered by insurance. And clinically, USPSTF anyway does not encourage DIXA scan prior to 65 in women and does not recommend it at all in men. So what I would suggest is for you guys just to absorb the fact that HRT was found to prevent osteoporosis. And this is a new update to our clinical knowledge simply because in the past 15 years, there is an acceptance amongst women younger than 60 to take HRT, so we were able to find that. Remember that people taught us that there is a benefit from preventing osteoporosis. I personally think I will be a candidate for HRT at some point. I don't do dairy. I don't necessarily cross certain BMI, hopefully. And there's a lot of musculoskeletal issues in the family with predominating osteoporosis later in age that was diagnosed due to other comorbid conditions. So I wouldn't necessarily mind being one of those observational cases. But it's not image dependent. It's not a DIXA scan dependent. That's a very good question. Omar, can you please confirm that I answered your question, please? And thank you for joining us while we network. Any other questions, guys? So some of you guys said you want to do A1C, lipid panel, TSH, urine microalbuminuria. Kareem feels strongly about figuring out and discussing statins. In his mind, he probably thinks an SSRI will help because she mentioned nervousness, sleep disturbances, some vasomotor issues. Probably her hormonal profile is nice and cute because she had progesterone breaks quite a few times. Menarche was around average age. She's still like, she just have like a year plus minus a couple of months of last menopausal period. And most importantly, I heard you guys say patient education, patient education, patient education, which is really great. So Ms. Diallo, you are so welcome. So that's great. Ms. Diallo is actually in good hands. Somebody mentioned obesity, BMI 34.5. So part of the patient education as, you know, like you're overdue for some blood work and some urine testing. We need to do that to make sure that your diabetes is well controlled. And this is really the biggest thing. Here are some things that may be happening in your body that we need to attend to. What patients on metformin for so long, especially women, may struggle with? What things you need to screen for according to the updated guidelines for people who have been on metformin for so long? والله أنا هزعل because it can pretty much explain her symptoms.
B12.
Give us a minute.
يا سلام.
Oh, B12. Oh.
Excellent. يعني دكتور مصطفى أنا لازم أعرف العنوان بتاعك. So yes, it's B12, and I cannot tell you how many times I have seen patients who have been on metformin only for so long, especially women with PCOS, and then they come, hands numbness and tingling, regular dizziness, cognitive irritability. They have been feeling temperature irregulation, and you know, like I have a large Nepali population who practice like Hinduism, and they don't eat meat at all. And you add metformin to this equation. I had people come with macrocytic anemia, and they had the full picture, like they can't remember, tongue hypertrophy, weird paresthesias, like full picture of B12. Like I've seen B12 of 50 on blood examination. So we'll add the B12 to the labs and see if that's the case. So we have done B12 to this patient. Then you talked about osteoporosis, and she's taking on and off vitamin D. She's, you know, she's African-American, dark skin. She wears they call it the sari. So she doesn't have much exposed of the skin to this sun, and she's always in the market. Do you want to examine anything else? And she's not on statins, and Dr. Karim wants to start her on statins. What do you need to check before that?
Yes, but the B12 theory is actually quite good because the patient's BMI is actually kind of protective against these symptoms, like the low estrogen effect of menopause, because the patient actually may have estrogen reserve. Like, yes.
I'm grinning, صح؟ أنا مبسوطة. سعيدة جدا, صح? So when you counsel these patients about their weights, you can be very positive by saying, you know, like, we know that your weight might be predisposing you to, you know, risk factors, but if we can actually get you to lower like 5 to 10 pounds, that would take you from 35 BMI, you know, it will take you from 35 to 30. That's really good. That's excellent, because you know that extra fat in your arms or your legs can help you provide some estrogen, right? When we are discussing menopausal symptoms or estrogen reserve. That's actually an excellent observation. There's actually benefits to the Egyptian mom, صح? She's African, they benefit from it. That's why I think African women, they do well. يعني I'm not really muted. مش عارفة دكتور مصطفى ممكن يساعدنا في موضوع الساوند.
I can hear you. Maybe it's a network.
طيب إذا إحنا عملنا ال A1C والليبid panel وTSH وurine microalbuminuria وB12. And I will throw into that لازم LFT, صح؟ إحنا عايزين ناخد CMP or LFT. CMP will tell us about calcium, will tell us about creatinine, will tell us about the liver enzymes. عشان لو I want to start HRT or I want to start statin, I want to know what the liver looks like, right? It will be a shame to have liver pathology or liver abnormality while we are planning in our management to start medications that can negatively impact hepatic metabolism. So I'll add a CMP. Vitamin D plus minus, you can actually add that. That's basically to provide therapeutic loading dose. عشان vitamin D 2000 units is going to do nothing if your patient actually does not have a good load. تمام? So you want to start them at either 10,000 daily or 50,000 weekly, and tell them that it's very important to take that for 6 to 12 weeks if potentially possible and they can afford it. تمام? طيب. Her A1C في حد تاني عايز يسأل أي سؤال؟ Dr. Mustafa, عايزين نكمل الcase discussion ولا we feel like we have things covered? Do you guys want to figure out how we manage this patient? How do you want to proceed for your best benefits?
If there's any inquiries, any
I think
questions?
yes. I kind of want to get to the end of it.
تمام يبقى هي we did the tests. She did have an A1C of 7.0. The lipid panel showed a little bit of elevated cholesterol. It was 215. HDL was 42, was like lower than her age group, and LDL was 97, and triglycerides were 168. And her TSH was within normal limits, actually more towards the higher, so it was like 0.9. And her B12 was actually low. It was 197. And CMP was unremarkable. Normal liver function test. Creatinine was 1.1 with a normal for her age. Vitamin D was also low. It was 27, so it's in the insufficient range. And urine microalbuminuria was less than 0.3, so she doesn't have microalbuminuria. And we didn't do a fasting blood glucose that day because she had already eaten before she comes to the clinic. So I sent her out to get the blood work. What do you guys want to do? So what I did, weight management discussion, scheduled her to come back in 3 months, discussed the statins, and I gave her a brochure about it. And I told her that, you know, that might be a good start doing some weight management exercise. I told her that HDL can improve through exercise the most, and kind of weak evidence of fish oil or including seafood in her diet. And increased her vitamin D to a therapeutic dose, so 10,000 daily, because she prefers a daily one instead of weekly one. And gave her B12 injections, kept metformin as is, and I told her to come back in 6 weeks. After all of that has improved, we need to recheck the B12 in 6 to 8 weeks, vitamin D in 6 to 8 weeks, and I did not recommend that she checks her blood sugar since she asked. I did not recommend that she checks her blood sugar every day. And she promised that she's going to work on losing a pound a week and then coming back to the clinic to reevaluate. And she accepted the fact that she might be menopausal. I gave her some information about sleep hygiene, improving exercise to kind of improve her secondary aromatization to DHEA. And as long as she doesn't have GSM or experiencing urinary symptoms, there is no point of giving her any topicals. And she agreed to that treatment excitedly. I prepared her for potentially that she might need some medications, and there are hormonal and non-hormonal options. I recommended she does some reading, and when she comes back, I can further discuss her treatment. That's probably most common encounters that you would have. You don't have to make a decision to give an HRT. The severe symptoms that impact quality of life in menopausal women are not as common as we would like to think. They are up to 15% of women. So maybe 1 to 2 in 10 visits, you would have someone who's really a strong candidate for HRT and would love you for offering that option and prescribing it. Questions or concerns before we conclude؟ برضه خدنا ساعتين. أنا قلت لك يا دكتور مصطفى ده بيحصل كتير وأنا بعتذر، هو بيشد
لا 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 يا دكتور سندس، والله احنا سعداء جدا يعني.
never mind at all. It's super awesome.
والله يا دكتور يعني ده
وانجيجنج،
بليجر.
وحضرتك دايما بتشاركي الناس في المشاركه في المناقشه، فده عظيم بصراحه.
والصراحة ساعتين يعني quite good يعني، لأن الساعة
Yeah,
ممكن تبقى
it
too
went quite
short في حاجة
fast.
زي كده.
20 more
انا
enjoyable.
مبسوطه على الحماس. انا الدكتوره مريم، دكتور كريم، دكتور مصطفى، انا عايزه اعرف العيادات بتاعتكم فين. انا عايزه حد يحب المرضى، فاهمين؟ عايزه حد بقى يحتضن المريض المسكين اللي بيعاني.
احنا متشكرين لحضرتك جدا يا دكتور سندس والله.
ما شاء الله ما شاء الله.
Thank you very much.
Thank you guys. Thank you so much for the opportunity, and inshallah to more, and congratulations on launching your program and for this opportunity. Inshallah you will be able to benefit the whole world through such a beautiful initiative. And I always believe in the butterfly effect. يعني زي ما بيقولوا بحصة بتسند جرة. So all of these little impact, little things, يعني if we can do the little things in a great way, I think we can leave a great impact. So I'm so proud to be part of this, and I thank you so much for humbling me into this platform. So proud of all of you, mashallah.
Thank you.
We're really appreciative for your time, Dr. Sandus. It's been really great, especially the patient education part and the scientific part. These are two most important points I consider for myself.
Alhamdulillah.
ان شاء الله نتقابل في محاضرات تانية ان شاء الله، ونعلن عنها على الصفحة. شكرا جزيلا لكل اللي حضر.
Thank you so much. You guys have a great weekend, inshallah.
That would be awesome. Thank you very much, Dr. Mustafa, too. It's been a great opportunity.
Thank you. Thank you. Assalamu alaikum.